session today. Dr. Shahina, I will connect with you separately and explain to you the problem. However, we can still go ahead with the remaining program. We can go ahead with our panel discussion. And I am extremely sorry. We sincerely regret for the inconvenience caused to all of you, but it is really something that is out of our hands. So,
No.
hello, Nirav. Am I audible?
Yes,
Yes,
sir.
sir.
Yeah,
Yes, sir, you
okay.
are audible.
Okay.
So, we will directly start with our
The
panel
panel discussion.
discussion.
Yeah, we can do that. Yeah. Has Dr. Bhuvan joined?
No, sir, not yet.
Not yet joined. Uh, so maybe he'll join at 7, as was, I mean, that was the panel discussion time. So maybe we can wait for him or we can convene back at 7. So,
Okay.
yeah.
Okay.
Yeah.
Good evening and welcome to all the faculties and delegates to today's highly anticipated webinar, HER2 in Breast Cancer. We are honored to feature leading experts from across the country to discuss evolving models in HER2 plus HER2 positive breast cancer. Before we dive into the presentations, we invite all the attendees to participate in a quick 30-second anonymous quiz. Kindly please scan the QR code on your screen to answer all the questions.
Anshika will just go ahead with the panel discussion, huh? Not the webinar. Yeah.
So, for our panel discussion, I'm honored to invite Dr. Bhuvan Chuk sir. He is a principal consultant in the Department of Medical Oncology, Max Healthcare, Saket, Gurugram. Our panel discussion is on HER2 in breast cancer. Negative is the new positive. Um, Over to you, sir.
Nirav, can you please share the slides? Uh,
Yes, sir.
because Dr.
So,
Bhuvan is
Yeah, yeah.
traveling,
Just
so
give me a
so
minute.
I think,
yeah.
hi everyone. I think I do see my panelists. We have Dr. Nancy there. We have Dr. Jonathan Alexander, Dr. Ukita, obviously also there. She's a brilliant pathologist and counselor. Dr. Jyotsna is also there from the pathology department. I think uh, that's the entire panel, or there is anybody else also? Like, am I audible?
Yes, sir, you're audible.
I, I'll just switch on the camera in a bit, but otherwise, thank you for the question, AstraZeneca. What we're going to do is we're going to have a discussion about the virtual new how the writing in negative with the new positive, and I think it's really great that we have a pathology Latin panel because I think the negative can only become positive if the pathologist gives it as a positive or ultra low, which I think is the need of the I rather reached out to AZ to obviously train the pathologist at least at Max Healthcare, on which we could really get to understand the the nuances of ultra low. So moving forward, can I just have the next slide, please? Yeah, so this, I think, was it not PB04? I think they just changed the slide. Anyway, so I think the initial excitement with HER2 low, not ultra low, but the HER2 low started with the DB04. In the DB04 trial, which was, I think, presented in 2023, if I'm not wrong, 2023. So, there was this entire conversation of how the TDXT had become the new standard of care after the first line of chemotherapy. So basically, you would treat your patients of hormone positive HER2 negative breast cancer, or majority of the hormone positive HER2, but some of the triple negative also. How you would treat with them, you get the first line of endocrine and the second line of endocrine, and then you would move on to the chemotherapy part from there. But as we understood that as we went along, there was a lot of excitement which came out of how the PDXD arm was better than the chemotherapy arm. And it was certainly, and you would probably do it after the first line of chemotherapy, and that's when it was tested in the second line cytotoxic arm. And it had clearly shown that the PFS as well as the overall survival was improved with the PDXD. The response rate was somewhere in the range of 50% versus 20, late 20% with the chemotherapy, and that's what established the BB04 as a standard of care. Can you have the next slide, please? Moving forward, then came the DB06, in which it pulled the TDXT from the first line, first one line of chemotherapy to the chemotherapy naive patients. So all these patients who have had exposure to at least one line of endocrine therapy, which in today's world probably would be a Momelisa 2 or a Peloma 2 or a Momelisa 3, you do them with a AI plus CDK inhibitors. Once they progress, how you could move on to the TDXT arm. So there are two options of doing it. Either you can move from one line of endocrine to a second line of endocrine and then on to TDXT, or depending upon the pace of progression, you can move from one line of endocrine therapy to the XT. So there was an interesting study and interesting data presented by Itya Bardia at SCDC, in which he had discussed how the pace of progression of the disease, and you could divide the progression of the disease as, let's say, 6 months, 6 to 12 months, and more than 12 months. How in the patient who had responded, who had failed within the first line, they were treated with TDXT and they were going to implement the PFS. And there's also a trend towards improvement in the oral survival is not mature yet. The response is in the range of around 60% versus 30%. So 50% as compared to 30% with the TPC, that's the treatment of resistant. And that's where it had said that TPC as in the TDXT becomes a new standard of care in the post one line of endocrine therapy. In the post one line of minimum post one line of endocrine therapy, usually most of these patients also probably would give a second line of endocrine therapy, but before they could be treated with any cytotoxics, they would be treated with the TDXT. Can I have the next slide, please? So I think it's time to move on to the case and we'll go to the testing. So we have a 60-year-old female who is diagnosed with a soft dyspnea and a palpable breast lump, which initially was around 4 centimeter in size, and then with when it was further evaluated, there was some suspicious micropulse, which made it somewhat large in size. So there was a PET scan had shown that there was right breast carcinoma with right lymphadenopathy, CT chest and multiple lumps with some interesting lymph nodes. Can you have the next slide? Biopsy was done from the right. So there was bronchoscopy was done on the right lower lobe of the right lung. It had shown that there is lung mets also. So it was basically formed as a metastatic breast cancer, which was the ER positive with 45% tumor staining, ER positive 55%, PI which was aggressive, 70% HER2 negative. The patient was started on Mona Lisa 2. The patient was started on ribociclib and letrozole with hyaluronic acid. The patient progressed after 1.5 years with new bony mets. And in the meantime, the patient's second time which started was palbociclib plus fulvestrant. So I think at this point I'd like to bring in Dr. Mansi. So in a patient such as this, would you be okay with shifting to a? Would you have rather done the patient only on a fulvestrant, rather than palbociclib, or you probably would have also made the same choice of adding palbociclib to that along with fulvestrant?
So I think I usually do post CDK4/6 inhibitor. If it was ribociclib, then I'd probably use everolimus. If possible, if there's no contraindications to an mTOR inhibitor, such as uncontrolled diabetes, and my usual go-to choice is doing fulvestrant with everolimus.
Great. So does it make a difference that the patient has had almost 18 months CFS on a CDK inhibitor? You think there can some juice left in CDK inhibitor which you can take out versus doing? I think it was what you're mentioning is it was a PFC 0102 trial. So the fulvestrant with everolimus can give around, if I'm not wrong, 11 months in the patient who were not exposed to CDK inhibitor in the phase 2 trial it was done. So fulvestrant plus everolimus data had come out of a phase 2 trial, which probably would give you 11 months as compared to 7 months with only fulvestrant in the second line after the progression on a first line AI. This was almost a parallel to something called as Bolero, which was a phase 3 trial, which was done during that time with the similar figures. So what you're suggesting is that doing mTOR with a hormone therapy or endocrine therapy possibly makes some sense. Does it matter that the patient has? Okay, would you do the same thing had the patient possibly would have done 6 months or 8 months or 10 months on the Mona Lisa 2, or does that the duration of response to the Mona Lisa 2 or a polymer 2 has a effect on the choice later on?
So I think in terms of the median progression-free survival, what we know is that with the first line AI with CDK4/6 inhibitor, we usually expect somewhere around 25 to 29 months. As long as the patient is kind of following that pattern, I think using a second line hormone therapy would be okay. If the patient is progressing at 6 months, 8 months, 10 months, basically lesser than what the median progression-free survival is, I think definitely rebiopsying at that point would make much more sense to see where we are in terms of the hormone status. Irrespective, I think doing a repeat biopsy at the time of progression, just to see whether we want to do hormonal therapy upfront. Looking at the disease burden, I'm not sure how much symptomatic the patient was. If I have to choose a CDK4/6 inhibitor post progression of CDK4/6 inhibitor, I mean, I usually go to the maintain trial. If the patient has taken palbociclib upfront, then adding ribociclib might give you 4-5 months additional. But on ribociclib, I usually don't re-challenge unless it's abemaciclib. With some data on abemaciclib. But again, like I said, I think, I think in the sense that CDK4/6 inhibitor progression, maybe choose another pathway to kind of attack the cancer and hence doing an mTOR inhibitor. You're right, we don't have much data of everolimus post CDK4/6 inhibitor. So I think based on experience, I've had good experience with it, and that's why it has been my go-to choice if the patient is still hormone positive and in the absence of a PIK3 inhibitor. So I'm sure you'll talk about that, whether you did molecular testing at this point.
So what I was trying to basically show was that, in the early, so the patient had a KI of 60 or 70%, and then if he's had a rapid progression, let's say somewhere around 6-8 months, one of the choices I probably would have considered is doing a 30XP directly then. And the reason I say that is because, when Dr. Badi had presented that SABCS paper, it kind of made sense that all these patients are almost behaving so aggressive that there may be some sense in, possibly doing a radiation directly. But I think let's move forward. Can you just go to the slide, please? The previous slide. Yeah. So the patient underwent palbociclib plus progression, which kind of gave her around 2-3 months. And once they gave her around 2-3 months, there was new liver metastases which were expected. Kind of, when you looked at the disease, you probably thought that she will develop visceral metastasis sooner than she'll develop visceral metastasis sooner than expected, and that would happen. Can we have the next slide, please? So I think this is a very valid question, considering that HER2 test was interpreted in a binary fashion of positive versus negative. I think it's a no-brainer to all of us here. Mansi is there, and the pathologist is also here. All of us, let me just ask the pathologist, because as a clinician, we all possibly do it. So I'll take it from, let's start with Dr. Sangeeta. To your thing, so we have 4 pathologists. Let me just take a vote out there. Have all of you simply migrated towards HER2 result not being a simple binary positive negative, or it is still a non-binary thing? But basically, what I'm saying is, do you still believe that HER2 is negative and positive in your head, or do you have started also expecting from the clinicians that they will cross-check with you that is it 0, 1, 2, 3, or is it 0 and ultra low? So, Dr. Ruchika, Dr. Sangeeta, Dr. Jay Mehta, and Dr. Jyotsna, your quick take on these.
Shall I start? Dr.
Yeah,
Bhuvan,
please. Please go ahead.
So regarding HER2, since June 2022, when we heard about the new therapy, antibody drug conjugate therapy for HER2 low, even we have started appreciating that HER2 result as binary fashion should not be offered. It's like a continuum, because when we say HER2 is 0, there are still less than 20,000 receptors on the surface. And when we say 1+, there are around 100,000 receptors. So it is not absolute 0, and then there is 3+. So there is 3+, which all of us, there is excellent inter-observer reproducibility, and all of us know that there are potent drugs available. But there is 2+, which is non-amplified, and 1+, that goes into HER2 low. And then there is HER2 0 is again, it is null and non-null. So we have started appreciating this, but CAP guidelines still doesn't permit us to write that it is HER2 null and HER2 non-null, but they expect us to mention the percentage, the pattern of staining. And what I have been doing in my personal practice, that even if it is HER2 0, so you report it as is expected by the latest current guideline, and then give explanation that less than 15% of the tumor cells show imperceptible incomplete staining. So that may be considered as HER2, non-null, or HER2 ultra low. So that's the way the report. So there we are expected to write a note explaining that now we are ready to target HER2 non-overexpressing tumors. So this is my take on it.
So Dr. Bhuvan, can I add to what Dr.
Please.
Sangeeta? Yeah.
You do
So-
add, and also tell me the definition of HER2. Also tell me the definition of HER2 ultra low in terms of the percentages. I think that will really help me and this.
Okay, so HER2 ultra low is said whenever you have membrane staining, incomplete membrane staining in less than 10% of the tumor cells. Then it is considered as ultra low. So the initial, what we used to say as negative, the 1+, so that can fall into our ultra low. However, if you have membrane staining, what you call an incomplete membrane staining in more than 10% cell, or you have a 2+, which is FISH negative, that falls into the HER2 low category. And 3+, we all are aware, if you have a strong, complete circumferential staining in more than 10% cells, intense strong, is that 3+. And just like Dr. Sangeeta just said, I agree. It's not binary because we anyways are doing 3. It's positive, negative, and there is an equivocal category. However, if we keep that equivocal aside, even in the negative, after the CAP guidelines in 22, when there was update and when there was talk about ultra low, we have definitely become more cautious while reporting the -0 and the -1+. We are not using these terms low and ultra low at the moment because our oncologists do not really ask for that. However, we are careful to mention if it is a 1+, and in case if in future it is required, if some therapy needs to be given, at least that can be taken into account. So this -0 and 1+, which were earlier just dismissed like that, are now being reported with caution at high pass so that you do not miss those kind of cells and staining pattern.
Great. I think to rest of the pathologists, let me just take it forward and then take it forward.
Yeah, just
Then take it from there. Can I have
to
the next slide, please?
yeah, can I just tell about our practice? We also do the same thing. We don't use the binary reporting anymore. So ever since this concept has come up, we are also putting up the score with the percentage of cells and the pattern of staining.
Just almost biopsy. It's basically a marker, it's not a consistent marker, and I think that's what it's trying to show. Can I have the next slide, please? Yeah. So can we coming to the HER2 expression? There is obviously this entire thing of how we obviously understand that we do not go with historical score. There's this entire thing of, kind of changing it to the doing a rebiopsy once you had a patient in which you had a patient in which it is zero, you biopsy it. But let me ask this. So if you had a patient who had a positive and uh, you did biopsy negative, uh, do you have any data which exist that can you still give them TDXT if the recent biopsies are negative? So, Dr. Mansi, first, what is your clinical practice? Do you still offer them? So let's say you had a patient who at the baseline, possibly in the upfront setting, when she was an early breast cancer, she had HER2 1 plus. When she was 2 plus whatsoever, and then when she became metastatic, it came out to be HER2 0, and then again you repeated it because you thought it'll change and still HER2 0. Would you need to give those people TXT, or you think that if it is negative, that's the end of it? I cannot give them TXT now.
So so I think in terms of HER2 2 plus tumors going to HER2 absolute zero, probably might not be that common, especially now because we have TDXT approved for the ultra low setting as well. I would definitely, go back to the pathologists and ask them to look carefully, even if there is any staining for HER2. Ultra low as being defined by less than 10% staining and bare perceptible staining, I would still offer them and HER2.
Yeah, I- to- there's no chance you can offer, because the last I checked this entire guideline thing, I could not find a reason to.
I don't know if I'm having technical issues, but I'm having a hard time like following.
Yeah, even I am
Some
not able
problem
to
with the
get the
audio.
audio. Yeah.
I don't know if the organizers
Lazy here.
can. Sorry.
Otherwise, let me.
Dr. Bhuvan, your audio is not clear.
I think sir has some internet issue.
Is it still not clear?
No, it's not clear, so it's a hard time to kind of follow you.
Yeah, well, your voice is breaking.
Is it any better now? Any better now?
Yeah, I mean, we can hear you right now. It kind of goes in and out, but you can start, and then we'll tell you if it doesn't
It has
work.
been inconsistent, so
Please go ahead. Please go ahead and do inform me. Can you? So there is a problem with my net. I do understand that. Yeah. So moving forward, any long share the slides. So this is where we were. There is obviously this prevalence of HER2 ultra low which has come up, and then obviously we understand that a lot of you have already started reporting is HER2 ultra low, and uh, incomplete stain less than 10% is what is defined as HER2 ultra low. Am I right, Dr. Ushika?
Yes.
Great. So a fresh batch in this, what you could see in this biopsy was that there was what you could see that is a 40% heterogeneity, but then The DB06 had an antibody from you is as a method. If you can offer me other institutes inside. So what other antibody are you using? B5 antibody or some other antibody which you use to detect the HER2 ultra low or HER2 10%? Dr. Ruchika and Dr. Jay Mata, I think both of you. Am I not audible now also?
Yeah, the voice is a little bit cracking.
Yeah, Dr. Bhuvan, your voice is, I mean, it's cracking in between, losing you.
It's inconsistent.
Yeah.
Sometimes it's okay, sometimes it goes.
Okay, I am so sorry. I'm again asking you, and 4B5 antibody, is it the most common antibody to be used for HER2 classification or is it different? To my pathologist.
Actually,
I think-
Ventana, 4B5 is from Ventana, and in addition to that, there are 3-4 other companies, and most commonly used is 4B5. But all those who are using other antibodies, they are supposed to standardize and get the antibody validated before putting it into clinical practice, especially for diagnosing HER2 low or ultra low. And in any case, the currently used reagents they were developed to detect HER2 3+. But here we are using the same reagents and trying to diagnose low and ultra low.
But then to the rest of the others, is 4B5 is the right antibody for it, or the other antibodies are also allowed to be used when it comes to detecting the HER2 low and ultra low? So all of you are using heterogeneous antibodies, or this is the right antibody for it?
We are also using 4B5, and I think that's the one which should be used.
Yeah, we are also using HER2 4B5.
Dr. Jay, your case?
Yeah, 4B5 is what everybody uses, and that's the antibody which was used in the clinical trial as well.
So I think the clear consensus is that majority of you are using 4B5 to report all the HER2s and especially the HER2 ultra low, is it?
That's
All
correct.
HER2s, yeah.
Yeah, great. So you'll probably know more this better than me, and I hope my voice is clear after the video has been switched off. But yes, so HER2 IHC 3+ is recognizable at 2.5 and 5x, 2+ is 10 to 20, and 1+ is at 40x. And I possibly have no reason to teach you all this because I still probably would come to you to understand all these. So there is a faint staining. So HER2 ultra low, as per the subjective definition, is defined as faint staining only detectable if at 40x. High magnification is required. There's an individual difference in color and the confusion with potential cytoplasmic and non-specific staining. For the sake of simplicity, as I would understood, HER2 0 is further divided into HER2 null and non-null. HER2 null is when there is absolute clear absence of entire HER2. HER2 non-null is membrane staining in less than 10%. Incomplete membrane staining in less than 10% is HER2 non-null or ultra low. HER2 1+ is, and HER2 1+ is incomplete membrane staining in more than 10%. How do you define HER2 2+? Sorry, in this continuum, how do you define HER2 2+, Dr. Jay and Dr. Ruchika? Hello? Hello?
Yeah, hi. So it's code
I'll
to be. Sorry.
Go ahead, please. I think one of you need to go ahead. All of you. So Dr. Ruchika, why don't you take it, and then you can take Dr. Jyotsna to take it.
So HER2 2+ is when you have incomplete but moderate staining pattern in more than 10% of cells. We call it a HER2 2+, and then we go in for a FISH to confirm whether there is any amplification.
So, and to understand me as a dull clinician, null is 0, absolute pure clean no HER2. HER2 ultra low is incomplete membrane staining in less than 10%. 1+ is incomplete membrane staining in more than 10%. HER2 2+
in this would be?
Complete membrane staining. But the
Complete
intensity
membrane
is
staining
less.
in more
Yeah.
than 10%.
Yeah, but the intensity is not
Intensity
as
is
good
less
as
and
3
more than
plus. Yeah.
10%.
Moderate staining. It's not a strong staining. It's like a moderate staining.
That's
But
the most
complete.
common pattern. Yeah.
But complete. Fair. So I think this is where the entire thing has to happen. And so do you all agree that, and Dr. Sangeeta is also here, so that ultra low has to be looked at the 40x and not at the, you can't identify ultra low below the 40x?
Well, it is impossible to appreciate that kind of staining at 10x or 20x. You have to go to 40x. Otherwise, you cannot report it.
Okay, so so we start with looking at the slide at, let's say, a 2.5 and a 5x. You're able to rule out the 3 pluses from there. Then you go at 10x, where you're able to rule out the 1, the plus, and then where you're absolutely able to say null and non. Have I understood it correctly?
Your voice is gone now.
So, uh,
Dr. Bhuvan, we can't hear you well.
there, guys, AZ, can you slide and let me speak? AZ, can you take over the slides?
Hello. Yes, sir.
Hello.
Slides. I hope it's slightly. AZ, can you take over the slides, please? Nirav, Anishka.
Yes, sir. Yes, sir. We have shared. Hello.
Yeah. I'm still to see the slides, but then moving forward, what? Yeah. So is that the way we understand these things is. So am I audible now clearly?
Yes, sir.
So we start with the 5x, 2.5 to 5x to look at the 3 plus, and then we move forward and we go to the 2 plus, we go to the 10x to rule out 1 plus and 2 plus, and then we go to the 40x to rule out null versus non-null. Have I understood correctly in this when it comes to it?
See, any pathologist will go from low power to high power, and to appreciate any subtle feature in any organ, in any biopsy, pathologist will go to the 40x. So that's the crux of the matter. This non-null type is very difficult to appreciate, or it's not discernible on low power. So one has to go to high power. So it's nothing, out of the way or something. Any pathologist would do that.
Great. So as per the CAP guidelines are there, I think there was an update in March 2025. Can we have the next slide, please? Are you guys aware of the CAP 2025 update, or
Yeah.
can anybody
Yes.
of you, Dr. Jay, can you please say it out, the CAP 25 update?
Yeah, so it has now made it optional to actually write the HER2 low scores and the ultra low scores, and you can actually call it low or ultra low. they made it optional, but it's something that almost every pathologist is now embracing and writing in the reports.
Great. So, have all of you seen this entire thing of guidelines, or is it so? Basically, what I'm asking is now is allowed, is what it is. At it. Hello.
What did you say just now?
Is it allowed to report it as a low and ultra?
No, CAP is not recommending that pathologists should call it low or ultra low. The original scoring exists, but then we have to qualify further. It's like right in the beginning when I offered my comment, when I say HER2 0, and if it is non-null type, I put it in the bracket. It's a note that it's showing less than 10% of the tumor cells are having very incomplete faint staining. So this may be considered as HER2 ultra low.
But
the original
Madam, the new
update,
Madam, the new
that's what
update
the new
says.
updated guidelines. That's what I'm trying
I
to
think
say.
that
So this
I
is
think
what
the next slide
the
says
new
that.
update is.
Yeah.
This is the new update. So the new update. Can we have the next slide, please? I think it is there on this slide, but we can look at the next slide also. Can we have the next slide, please?
Yeah. So it is 0 and 0 plus. Instead of
Yes.
that, it can be null and non-null.
So basically, that's what. Can we go to the previous slide, please? 1 second. Yeah, 1 second. No, next slide. Usme there is the red highlighted one is the orange highlighted one is this. Yes. So CAP 2025 updated optional is there is a HER2 0, 0 plus, 1 plus, and 2 plus can be individualized as follows in Destiny 04 and 06. HER2 low was considered as IHC score 1 plus and 2 plus. HER2 ultra low was considered as IHC 0 plus. Just a slide before, please. Can we go a slide before? Yeah, so if you look at the reporting criteria, which is there on the right-hand side below, this is where the result categories come in. There is a HER2 0, there is 0 plus, there is 1 plus, 2 plus, and 3 plus. And I think this is probably what Dr. Sangeeta is also trying to illustrate, that the entire recommendation has changed to that 10% thing which you want to raise. So instead of writing at 0, the 0 has been further divided into 0 and 0 plus. I think that's, do we all agree on that? Have I understood it correctly?
Yes, yes. Yeah.
Great.
Ma'am, so
Can we
we
have the
put
next
in a
slide?
score of 0 plus for ultra low, right?
Yes, I think that's what the entire thing is. That there is a 0 plus for
I
ultra.
mean, I would prefer still null and non-null.
Non-null.
So
Okay.
that sounds much better than 0
But
plus.
there is the CAP homogeneity is 0 and 0 plus. So
Yeah,
I don't know.
okay.
I think
It's always
I think
best to
that's
explain that how the proportion and the intensity of staining and pattern of staining.
so. I think that's what is written. 0 plus membranes incomplete and faintly barely perceptible within less than. I think that's the definition which we will obviously discuss now. But in that sense, this new 125, which is next slide, please. I think that was a thank you slide, if I'm not wrong.
So
Yeah.
can
So thank you all.
Dr. Bhuvan, just a minute. Could I just take one question? If I could just ask Dr. Sangeeta and Dr. Jay.
Please, ma'am.
So, ma'am, have you started using, because the CAP says reporting based on percentage is fine, but are you using the terms low, ultra low, or you're giving it like the way you said, a descriptive comment only?
See, whatever is CAP recommending, you have to follow that. But in bracket, it is always right. It is advisable to write a note explaining, because even the oncologist may not know and understand the percentages and why are we suddenly calling 0 plus or something. So it's always better to mention proportion, pattern, and intensity of staining, but give a conventional report, whatever is CAP recommending as of now, because it's a very dynamic field.
And they've also mentioned brackets, they've written optional also.
Exactly, because here we are, and the note also should say that we are now ready to target non-overexpressing HER2 levels in breast tumors. So this is why we are doing all this.
On a lighter note and on a more
Thank
authentic note, I think we oncologists will be pretty much open to getting new things. And if you start writing 0+, that will make our life easier, because it becomes easier for us to explain to the patient why we are doing and HER2 such patients, because it kind of homogenizes the entire HER2 ultra low definition. So that's from my side as an oncologist. But I think possibly following it up and saying 0 and 0+ would probably make our life easier also.
Dr. Ruchika, you asked, and I do write the narrative as to what the score is, but I also write low and ultra low, because the oncologists are conversant with that thing, the words that they understand. So post the March 25 update, although it says optional, I exercise that option to write it as low and ultra low.
Right. Thank you.
Thank you so much, sir, and all the panelists for making this panel discussion interesting and thought-provoking. Now, moving ahead with our agenda, I would like to invite Dr. Aparna Dhar ma'am. She is the director in the Department of Precision Oncology and Genetic Counseling at Max Healthcare, New Delhi, and she is going to talk on liquid biopsy in breast cancer. Over to you, ma'am.
Hi, good evening, everybody. Just give me a minute, just share my slides. Can you see my slides?
Yes,
It is
ma'am.
visible, ma'am.
Yes, all right, it's in play mode and we are good to go. All right, so good evening, everybody, and thank you so much for having me here today. I do know I'm the last talk of the evening, so I'm going to try and keep it very short, very sweet, and let's get moving with it. I've been given quite the task to walk you through the role of liquid biopsy in breast cancer, but I think we should first ask ourselves before we go on to liquid biopsies is there really a role for profiling in breast cancer? So when we think of breast cancers, we have this is a very basic view of understanding patients with breast cancers. They can be classified based on their ER/PR and HER2 status. The hormone-positive breast cancer is our majority, followed by the triple negative. In our neck of the woods, these percentages are definitely much more higher. And then you've got your HER2 positives. But honestly, we've, I think, gone beyond the very classical, intrinsic subtypes, such as your HER2 positives, your luminal A and Bs, and your basal subtypes. And we start to look more for genomic drivers. We've gone beyond the simple classification. We're looking for alterations in the PIK3CA pathway. We're looking at the DNA damage repair pathway. We're looking at resistance mechanisms in the ER signaling pathway, those growth receptors like FGFR1. And all of this could potentially allow us to target our patients with metastatic advanced breast cancers definitely in a more precise way. And I think the study very beautifully illustrates a molecular landscape about how breast cancer is very heterogeneous as a disease. As you can see, even within the subtypes over here, you've got your HR positive, you've got your, sorry, your hormone positives, your triple negatives. There's a plethora of somatic aberrations that can occur. And if you actually compare the difference between the primary and the metastatic site, at least 9 driver mutations, like your TP53, ESR1, AKT, were actually more frequently mutated in the hormone-positive breast cancers in the metastatic versus the early. And if I look at the metastatic triple negative, it actually showed an increase in the frequency of those biallelic losses of function in genes that were related in homologous recombination repair. And your metastatic breast cancers also showed a higher mutation burden and clonal diversity compared to early breast cancer. So now the poster child for building those, very beautiful molecular profiling treatment algorithms is lung cancer. But I personally think breast cancer is not far behind. So again, a very simple view of patients with breast cancer. And what this flowchart does, it essentially alludes to the fact that the only 3 biomarkers are ER, PR, and HER2/neu. What it's also saying is that the biomarkers stay static, which we know is not true. In about 30% of our patients, especially those that are on progression, there can be a loss of function. And 3, it also assumes that there's only one activated pathway that is dominant. And again, we'll see in a bit that it's actually a crosstalk between multiple pathways. So if I look at the tumor biology, let's look at triple negative breast cancers. We know they're typically associated with the worst prognostic outcomes. And you can see in these heat maps over here that patients with triple negative breast cancer, it's not as simple as we think. Even amongst this group of patients, we see subtypes like luminal. We see the luminal AR, we see mesenchymal, we see basal immune suppressed, basal immune activated. And among each of these subtypes, we actually have different treatment strategies, such as immunotherapy for basal immune activated, PARP inhibitors for those with alterations in the DNA damage repair pathway. And then you have immunotherapy combinations in your basal immune suppressed subtype, and of course, anti-androgen therapy in your luminal AR. So it's not a very simplistic view. Now, what we have here is what I think is the optimal molecular diagnostic algorithm for our patients with metastatic breast cancers. So you can essentially, target the defects in the DNA damage repair pathway where PARP inhibitors and platinum therapy have very clear roles. You can also target the inflamed phenotype where, inflamed phenotype where immunotherapy has a very clear role. And then the AR pathway, so simple, a simple IHC. Again, we have agents for it, and alterations in the PI3K pathway. We have AKT inhibitors, and last but definitely not the least, those agnostic markers. And you've got your HER2s, you've got your NTRK fusions, you've got your BRAF V600Es, your RET fusions. There's some amazing data coming out where we're seeing the role of EGFR, especially the T790M in our triple negative breast cancers. So there's a lot of great work that's happening over here. Now, if we look at the hormone positive, and again, this is just my view, but I think this is the very ideal molecular diagnostic algorithm. You've got, obviously ER/PR as potential biomarkers, but we also need to start looking at the different pathways, such as those that acquire an ESR1 mutation, because we know agents such as aromatase inhibitors do not work well here. You'll need to look at agents such as fulvestrant. Again, in the HR positive, you are going to find defects in the DNA damage repair pathway. From the Olympia trials, we do know PARP is an option. Then you can look at the PI3K, AKT, PTEN pathways and your agnostic markers. I'm not really sure how great immunotherapy works in an HR positive. There are ApoBec signatures that do allude to sensitivity, especially when you see high TMBs in these. But again, there's some brilliant work around it, but maybe it won't be ideally my, it's definitely there as one of my treatment options, but maybe not my most favorite. Now, again, I've just, further gone and personalized it based on the endocrine sensitive. These are more my advanced stages where we start off with CDK4/6 inhibitors and aromatase inhibitors. And based on the PIK3CA status, we go ahead when the patient progresses and come up with these various treatment options. So there's a lot happening. Now, in the hormone positive cohort, and there's a reason I'm going to spend a little time here, is that the tumor biology of this disease is, I think understanding it should really be the new norm, because the reason being, our patients do acquire endocrine resistance. And what we see is that these endocrine resistance are there in their tumors, and they're starting off as very, very small clones of, let's say, an ESR1 mutation that, when you give them hormonal therapy, so in about 18%, they actually acquire an ESR1 mutation. 13% have a problem, a defect in the MAP kinase pathway. Then around 9% have acquired mutations in the MYC pathway. And these genomic alterations eventually result in endocrine resistance. And for me, oops, what happened? Oh, here you go. And I think for me, when I look at my hormone positive, I think this triangle is the one that emphasizes on the three most important nodes in the signaling network. On one hand, you have the estrogen receptor, ER. On the other, you have the CDK4/6. And up there, we've got a PI3K. So whatever you do, the ER-positive breast cancers with one of the angles, with one of the signaling nodes in this triangle, the other two gets activated. So if you try to block the ER, the PI3K and CDK4/6 start. If you block the PI3K on its own, ER signaling goes up. And that's why we've never, that's one of the key reasons you never give a PI3K kinase inhibitor as a single agent, because you have this adaptive increase in the other components of this triangle. And this triangle also shows the new age of clinical trials, right? Now we know there is some great clinical trials going out there where they're not just developing various doublets, but they're actually looking at triplets where you can kind of use various combinations in blocking all three. And that's all three angles. And that's why understanding the biology here becomes extremely, extremely important. So We do know that ESMO has actually come out with a scale of clinically actionable molecular targets specifically for breast cancer. This is those SCAT scales of this, and you can see the level 1, level 2, tends to be in terms that you're looking for. Classical, what I showed earlier, HER2, your germline BRCA1, BRCA2. I think germline and even somatic PALB2 has made an entrance over here. PIK3CA, MSI, NTRK, ESR1, PTEN, AKT1, the usual suspects. And then they also have a plethora of different targets, which has less evidence that supports it, but we're also looking at them from clinical trials. But a lot of them are also prognostic factors. So you've got ESR1, which we've discussed. There's a lot of great studies that's showing how ESR1 is there from the get-go, a lot of times lurking around as a small clone. Then in your patients who've been on CDK4/6 inhibitors, one of the most commonly acquired resistance mechanisms is RB1, which again kind of hints at maybe it's important doing profiling upfront when your patient progresses to see what the molecular landscape is of your patient. And I think this is a very beautiful study of over 8,500 patients who were targeted, where they've used molecular targets, and they've gone beyond the classical, the ERBB2, the HER2, the ESR1, the HRIO deficient, and they've actually looked at the FGFR. You've got your CDK4/6 pathway, you've got your other kinases that we do know do get disrupted, and that's where molecular testing and profiling becomes so very important. This is again a very beautiful flow chart illustrating the same, where it's become so important to understand the genomic landscape. So coming to it, now, is there a role for breast cancer? Absolutely. If you've got all these biomarkers lurking around, how do you detect it? You detect it by doing profiling. And let's face it, a lot of these resistance mechanisms come in such low variant allele frequencies that the sensitivity of picking them up tends to be better with liquid biopsy. And why is that? Because we do know that we have heterogeneity, both inter and intratumoral. And that's because of that, it becomes a problem when you're actually trying to trace those resistance biomarkers in your patients. So one way that we're really able to look at the genomic landscape is through a liquid biopsy. So essentially, you're looking at the circulating tumor DNA, which is the somatic, the tumor DNA, which is being discarded into the bloodstream. ctDNA is isolated and it's studied. A lot of time it gets confused with CTC. CTC is essentially cells that are intact cells that are discarded into the bloodstream. Due to paucity of time, I'm not going to be talking about it, but there's some really, really great work that is happening in this area. And this is, again, just showing the intra and inter-tumor heterogeneity that we do tend to see in our patients. I'm going to show you a couple of studies so that maybe help clarify this better. So we can use liquid biopsies in various aspects. There's a beautiful thing with screening and detection. There's the Eclipse trial that is there, which is showing the role in screening. And we are looking at MRD, where there are a couple of interesting studies where we're looking at it for more a screening and recurrence perspective. And then we've got but for today, I'm just going to be talking about the resistance mechanisms, identifying tumor heterogeneity, identifying targets, which is what we tend to do more in our advanced and metastatic disease. So a question that we often ask ourselves is, what is the clinical utility? What is the benefit of looking at ctDNA in metastatic disease versus why not just profile the primary tumor? And this was one of the key objectives in the MIRROR study. So what they did, they evaluated the concordance of genomic variants between the primary tumor tissue and ctDNA in patients with metastatic breast cancer. And what they found out was that there was around 97.2%, there was a chance of finding a mutation where variants were identified in ctDNA. 13 variants that were identified in the metastatic testing was not present in the primary tumor, and that ctDNA definitely was not inferior. And here's another trial where we've used liquid biopsies in over 4,400 odd patients. And just look at how it's heterogeneous. And this is using liquid biopsy. This was done on the Garden platform. And just look at how heterogeneous you've got, how heterogeneous these breast cancers are. This was, again, another excellent study that looked at the mutational landscape using ctDNA in metastatic breast cancers. And out of the 105 odd cases that were there, all of them had a G360 done, which was a liquid biopsy from Garden. 54 had the foundation on tissue and 44 did Tempus. And again, what we saw here, and I'm going to look at our usual suspects, the PIK3CA is the ESR1. Tissue had a 7.6 pickup rate for PIK3CA. ctDNA was as high as 11.4%. In ESR1, the tissue biopsy pickup rate was around 3.8, and liquid biopsy was around 11.4. Then we've got another trial, and I think this kind of set the ball rolling and getting our interest with ctDNA. It was one of the first largest clinical trials in the realm of breast cancer, and this was the plasma MASH trial where we had 5 cohorts. The 5th cohort, I don't think the data is out just yet. But the first 4 cohorts, patients were classified as per their ER/PR HER2 status. There was molecular profiling done. And what we saw over here is that we first had a head-on-head comparison of NGS, liquid biopsy, where we've used Garden 360 with DDP, digital droplet PCR, where we look for those very common mutations, PIK3CA, ESR1, AKT, and HER2. No brainer. We do know that you're comparing a hotspot to a full gene panel. Obviously, Garden had a far, far more pickup rate. So again, in a liquid biopsy versus liquid biopsy head-on-head comparison, NGS ctDNA was far superior. What we also saw over here is that based on the NGS reports, is the treatment was administered based on the molecular profiling. And it again cemented the fact, I'm not going to go into the treatment outcomes, but again cemented the facts about being on those molecularly matched tumors, how patients tend to do much better. And ctDNA was definitely a reliable platform. This is one of a newer study. This is Vidula et al. And again, they did tissue versus liquid for match studying and seeing the impact on breast cancers. And I think the beauty is that 92% mutations were seen on ctDNA and only 76 was seen on tissue biopsy, which was from the new metastatic site. Again, hence proving that liquid was not inferior to tissue. So another question is that, so could you actually use liquid biopsy to detect these driver, mutations that are known for, driver mutations that are known to be resistant, detect the driver mutations for your treatment and simultaneously pick up those resistance mutations, early versus tissue. And this is way back, I think in 2018, where Dr. Chandralapati presented this in ASCO. So imagine way back in 2018, the previous trials I showed you were like 22, 23. So even over there, what they saw was that this was a case from MSKCC where there was a ER positive patient with invasive ductal carcinoma, started on treatment, and what they saw when they did a comparison of tissue. So let's just pick up the ESR1. Now at baseline tissue, ESR1 was 0. Then they repeated the biopsy. They again checked for tissue in July. It was 0.32. Vis-a-vis when they did ctDNA testing, I was picked up as early as Feb of 2015. So yeah, I think somewhere liquid biopsies can do it. Again, this is a very nice study that has said that when we do tissue versus liquid, in the ctDNA, they've actually been able to pick up 84% actionable mutations versus the 66 on tissue testing, which further cements the fact that liquid biopsy is not inferior to tissue. Now, the flavor of the season is a PARP inhibitor. So I very, very quickly want to draw your attention to a very important concept called BRCA reversion. And this is something that can be picked up predominantly and primarily on liquid biopsies. So in our heavily pre-treated patients, BRCA reversion is essentially a phenomenon whereby the BRCA alterations have the potential to restore their reading frames. That means revert back to the wild type sequence or remove all initial deleterious alterations, and they restore at least partial BRCA function. Especially BRCA2 is more susceptible. And this was a beautiful case study that demonstrated this concept. So this was a BRCA positive patient, post multiple lines of treatment. They did BRCA testing, germline, they found a BRCA mutation. The same BRCA was found on tissue. Started on PARP, had a PFS of barely 8 months, then progressed. They added chemotherapy. She continued to progress. They did a liquid biopsy, which confirmed that there was a BRCA reversion. So this was done on liquid biopsy. Tissues cannot pick this up. Now, there are some great things that are happening around with tissue, but there are some with liquid, which we're aware of, but this is a garden session, so I did want to highlight some of the new features that have come about that I'm very excited about, especially with respect to breast cancers, and that is the concept of adding methylation signaling to the NGS, and I'm talking liquid biopsies in particular. So epigenomics, using methylation studies, it actually unlocks a mechanism of regulation that is invisible to our genomic testing. And this is such a simple, illustration, but it so beautifully shows that in breast cancer, around 25% of your triple negative is actually driven, 24%, not 25, is driven by promoter hypermethylation of the BRCA1 gene, as opposed to the genomic silencing that happens through mutation deactivation. And this signature has become very, very clear under the genomic lens, under the epigenomic lens, as we can see in this slide here. And it does give you insight and opens a new treatment avenue for those patients that we could potentially consider treating with a PARP inhibitor. And this is just some of the new features that are added in, but I think the beauty is the fact that the promoter methylation has come in, and it's not just breast. We can use it in ovarian because of the BRCA1 methylation. We can use it in colorectal cancers and a plethora of others. So very quickly, in the next 5 minutes, 2 minutes, I'm going to very quickly walk you through what I do in our clinic and walk you through some of the case studies. So ideally, metastatic breast cancer, is molecular profiling required? In an ideal world, yes, I would love to know upfront what's happening, but cost is an issue. So if cost is an issue, I'd say no, we don't do molecular profiling upfront. When there's disease progression, we see if tissue is there, we go ahead with tissue. If tissue is not possible, then we do liquid. If tissue is there and we don't get an actionable target, again, this is a very ideal world. We can consider doing liquid biopsy, or we wait, watch, and on the next progression, do a liquid biopsy. Now, if there is upfront NGS happening, and a lot of times when these patients come to our clinic, they've already gone through 1 or 2 lines of treatment. So my knee-jerk reaction usually is to say yes, while liquid tends to be my preferred way because tissue becomes an issue, unless I have some complexity around defining the ERPR HER2 status. If I need to get that done, then tissue is done. But a lot of times we just do liquid biopsies. So 2 very small cases in our clinic. This was a patient back in 2016, 46-year-old female. She had metastatic breast cancer. She was started on CDK4/6 inhibitor. She was, ERPR positive, HER2 negative. She had a oophorectomy, even though she was germline negative, but that was a personal choice. She was started on a CDK4/6 inhibitor. Then around 3 years later, she came with complaints of lower back pain. On evaluation, they saw that it was progressive disease. Because it was predominantly in the bone, we couldn't do a rebiopsy, so we sent it in for molecular testing using liquid biopsy. And there you go, we found a PIK3C and ESR1, very classically seen. We started the patient on fulvestrant and alpelisib. Unfortunately, this patient did pass away. She had complications due to other comorbidities that she developed post-diagnosis, but she did get a PFS around 7-8 months on this drug, which I know is very hard to use. Here's a 36-year-old female, triple negative breast cancer, ER positive, ER positive, PR negative, and HER2 negative. She had a germline BRCA2 mutation. She had the very classical NACT followed by surgery, adjuvant radiation, and was put on a combination of olaparib and tamoxifen by her treating medical oncologist. She had a very short PFS in 3 months. She had complaints of axillary swelling, so they did an FNAC, and now it was metastatic disease. Lymph node was positive. So we did complementary testing over here, and that was a time when Garden had a bundle offer going on. So we did a ctDNA plus a tissue testing. And when we did tissue testing, we picked up the BRCA mutation, which was her baseline germline. We saw STK11, TP53, MYC amplification, some of those known resistance mechanisms that popped up. What really stood out over here is if you see, oops, this has gone up. If you come down and you see the BRCA2 deletion, that's the BRCA reversion, not what I've highlighted. So that was a BRCA reversion that we've picked up on a liquid biopsy, and the patient was started paclitaxel as there was a BRCA reversion. So yeah, NGS, I do feel in the realms of breast cancer is extremely important. I do see it as one of our heterogeneous diseases where ctDNA in particular does help guide treatment. It's not invasive. It's definitely much easier. And, be it your PIK3Cs, your ESR1s, the pickup rates are far better off in liquid biopsy. We saw that in the SOLO-1 trial. We've seen it in a host of different trials where liquid biopsy was definitely not inferior to tissue. And on that note, thank you very much for your patient listening.
Thank you so much, ma'am, for such an interesting talk. Now, since we don't have any questions from our audience, we will wind up. Thank you everyone for joining, all our audience and speakers. We look forward to welcoming you in future programs. Wishing you all a wonderful evening. Thank you.
Thank you.
Thank you, ma'am.
Thank you.